Mr. Miller, you seemed as though you had something to say.
Well, there's one view of the world which says simply, pour more resources in and everything will work wonderfully. The problems with our healthcare system are what we're getting out of it as well as what we're putting into it. And so a singular focus on just adding more dollars for more inputs says nothing about the quality of the care, its efficiency, its alternative delivery. We need to make lots of changes in a lot of things in order to get a better healthcare system. It is not should not be solely focused on, let's just have a lot more physicians and everything will be great. We've tried that approach before. It doesn't produce the results. Now, there are barriers to production of physicians, which we can talk about, but it isn't solved simply by increasing federal funding.
Okay, I appreciate that comment. Several of you have testified that the match system harms rural hospitals. I'm from Wyoming, which is a very rural state, dealing with many challenges in its ability to provide healthcare services and with barriers related to financing, transportation, and access. Dr. Lynn, is it difficult for rural hospitals to meet ACGME's accreditation requirements?
It is challenging, Congresswoman. Number one,
what are those challenges?
Some of the challenges are some of the standards that they put in place that, for example, distance radius. Obviously, if you look at rural America, there are 1,300 critical access hospital, and by critical access hospital, by definition, there are less than 25 beds. So given that, if you're training a physician, obviously scope and volume becomes a problem. So when you're trying to train a rural program for residents, you have to send them to distance away for training. And one of the barriers to that is that, for example, our orthopedic program got shut down because we have to send our residents to Cincinnati Children's Hospital, and we have a consortium model that we have partnership with them, and that was not acceptable to them. So that creates a barrier where we're trying to increase quality and scope and volume for our residents, and they thought that was a negative. We got cited, and that was one of the reasons why they closed down our program.
So do you have some ideas of how to fix those kind of accreditation problems?
Yeah, absolutely. If you look at prior to 2015, the merger of the ACGME and the AOA, there was an alternative accreditation body, which was from the AOA. And if you look at prior to the merger, we have most of osteopathic institutions have a consortium model where we have a network of small community hospitals and or community hospitals, and we sort of leverage each other's strength, and we put in the consortium model that we have a network of training sites that we can send our residents and collaborate. And that model has worked out for many, many years. Mill Creek Community Hospital, which now is called
Why was it changed?
It changed because
of the merger?
Of the merger, that's
okay.
Correct.
Specifically the issue that this committee addressed antitrust is focusing on, correct?
In my opinion, yes.
Okay. Mr. Miller, there is persistent and growing shortage of medical professionals in this country. And again, representing a state like Wyoming, we seem to be hit harder than many others. Do you think placing qualifications on job positions that are not based on merits, such as the DEI requirements, exacerbates the challenges our nation is facing in terms of providing care for our citizens?
Well, it sounds like a euphemism. You know, the goal is to have everything based upon competition, quality, and merit. The rest of the distinctions are ancillary and can be distracting from that. I don't want to overstate the magnitude of DEI, and this is going to fight its way out through the courts. We've got rulings. They're going to be interpreted, and some games are going to be played in the educational system in general, not just for physicians. But the more we can focus on what physicians are doing at the point of care and what they're producing, that's what we want to measure, as opposed to any other ancillary considerations. But I think that's going to work itself out through further litigation, probably more so than random interventions.
Okay. Mr. Merrick, very quickly, this hearing focuses on the antitrust exemption granted by Congress, but you were hired in the 1990s as part of a lawsuit against the match system. The National Resident Matching Program, also known as MATCH, was founded in 1952. The ACGME was established in 1981. How far back does the harm for your clients and other medical students go?
I think the harm goes all the way back to 1952, frankly.
From the beginning? Just
Exactly.
created the program
Exactly.
itself? All right.
People got their positions by telegrams back in 1952. The problems then have no relevance to today, in my view.
General.
Okay, thank you. I yield back.